Hi everyone, and in this video, we'll be discussing a new topic that is immunomodulators. Immunomodulators have two important things. One is immunostimulant, and one more is immunosuppressant. Immunosuppressant is a major focus of discussion in this video. Now, please imagine what are the conditions where we want to suppress the immunity. Obviously, when the immunity is more. Now, where the immunity is not important for us or we should suppress it is in a condition called autoimmune disorder. Second, when we are transplanting an organ, for example, you are taking somebody's organ and you are transplanting to the other person, the other person's immunity will not allow the organ to be transplanted, so it will mount an immune response. So, in that cases, we have to use immunosuppressants. Now, the problem is when you suppress the immunity, there is a chance of opportunistic infections. There is a chance of certain cancers developing in that patient, for example, lymphomas. So let us understand the topic immunomodulators and we'll take certain cases and with that we will continue. Now first patient is a 45-year-old patient and needs to undergo liver transplant. So when you have to liver transplant, you have to suppress the immunity so that liver stays inside and it is not destroyed by the immunity. A 55-year-old woman with rheumatoid arthritis needs treatment. So rheumatoid arthritis is an autoimmune disorder. We need to suppress the autoimmunity. And we have other drugs called DMARDs. We'll discuss it later in a separate topic called drugs for rheumatoid arthritis. A third patient, she is a 60-year-old male. He is a 60-year-old male patient and he has a coronary stent due to coronary artery disease. The stent is medicated to prevent stent blockade. Now, what happens when you put a stent in the coronary artery? Stent is a foreign object. Now, when you put a foreign object, the immunity will mount on that and there will be stent stenosis or stent will get blocked. So, how do you prevent that? Is there any medication to do that? We'll understand that in this topic. So, let us start our journey. So, what we are starting now is a topic called immunomodulators. So, immunomodulators. So, in immunomodulators, we have two concepts to understand. What is that? We have certain things called immunostimulants. So, we have immunostimulants. So, they increase the immunity. Examples are the BCG vaccine. So BCG vaccine is given to increase the immunity and destroy the cancer cell. So it is used locally for intravesical. It is given intravesical for treating what? For treating superficial bladder cancer. For treating superficial bladder cancer. So it is given locally as an intravesical therapy, BCG vaccine. It mounts an immune response to kill the cancer cell. Second, we have the interleukin 2 analog. So we have the interleukin 2 analog and the name of that is called aldesleukin. Aldesleukin. So remember, usually the interleukins will have leukin in their names. Now where to use it? It is used in the management of renal cell cancer. And one more is melanoma. We use it in the management of melanoma. So here also we are boosting the immunity. Third important is a drug called levamisole. Now levamisole basically is an anti-helminthic drug. Now it is used in certain cancers with the 5-fluorouracil and it is used to treat colorectal cancer. Colorectal cancer. So these are the immunostimulants what we have. The BCG vaccine, interleukin 2 analog, levamisole, right? Moving on to another important aspect, what we are going to discuss now, these are called immunosuppressant. These are called immunosuppressants. Now, where do you want to suppress the immunity? Let us write down them. Number one, in the management of autoimmune disease. So, autoimmune disease, we have to suppress the immunity. Second is when you are transplanting the organ transplant. Number three, where there is a disease called graft versus host disease. Graft versus host disease. And when you are using medicated stents, so then we have to suppress the immunity locally. Not only that, certain allergy, we also suppress immunity. So what is the problem when you suppress immunity? I told you the problem of using immunosuppressant, there are two important problem is patient are prone for opportunistic infections. So they are prone for opportunistic infection. And we know steroids. So steroids also immunosuppressant. So we saw that in pandemic when we used steroid, patient had mucormycosis. Same thing you can see in HIV patients. HIV patients are immunodeficient and they are also prone for opportunistic infection. Second, they are prone for cancers. For example, lymphomas, leukemias, their cancer growth can also increase with them. So this is the problem when we use immunosuppressant. So we understood the concept here. Now, once we understood the concept, how do we suppress the immunity? And you know that the cell-mediated immunity is by T cells, the humoral immunity is by B cells. So what we can do is we can decrease the T cell activation. We can decrease the T cell activation. Number two, we can decrease the B cell activation. So these are the major thing what we can do. So either we can suppress the T cell activation or suppress the B cell activation. So if I suppress this, there is decrease in cell mediated immunity. And if I suppress this, there is decrease in humoral immunity. Okay, humoral immunity is suppressed. Now let us understand the first one, how to decrease T cell activation. How to decrease the T cell activation. Now let me tell you the basics first. Now what happens? Whenever some foreign article or foreign thing is entering, it is called antigen. So whenever the antigen comes to the picture, for example, an organ is being transplanted or something foreign antigen is there. So there is a cell called, and this cell is called the antigen presenting cell. So this is the antigen presenting cell, and it has to give the message to one more cell, and that is the T cells. So the antigen is presented here, the antigen is presented here, and it is taken up by the receptor in the T cell. And what happens? The T cells has to undergo activation. So T cell undergoes activation. Now when the T cells undergo activation, they release something called interleukin 2. The interleukin 2 acts on the same T cells. There are receptor called interleukin 2 receptor. When it acts, what happens is there is T cell proliferation. So when the T cells proliferate, what happens is the immunity is mounted. So you see the T cell, that is cell-mediated immunity is seen. So whenever the antigen is exposed, the antigen presenting cells is activated, and that will give the antigen to the T cell, and they release interleukin 2. The interleukin 2 acts on the same T cells, and the T cells will proliferate, they will multiply, and the immunity is boosted, and that will attack the antigen. Now, the next important thing what I am going to discuss is, I will divide this like this. What is happening in A? What is happening? How come the interleukin 2 is released? And the next one is, what happens when the interleukin 2 receptors are activated? What happens next? So we'll discuss that. We'll discuss A, B, and C. Now A is what happens when the antigen presenting cells gives the message to T cells. So this is the antigen presenting cell, the macrophages, and this is the T cell. So this is the T cell. Now what happens when the antigen comes to the picture? The antigen is presented to the T cell. Now there is a receptor called T cell receptor. So T cell receptor will take this, and there is activation of CD3. Now to mount an immune response, there is also activation of one more factor, and the factor is called CD80/86. So CD80/86 should also activate one more receptor in the T cells, and that is called CD28. So this is CD80/86 is also called as co-stimulator. So it is also called as co-stimulator. Now, if I want to block this immunity, what should I do? I should block the CD3. So CD3 is blocked by a drug called Muromonab. So the name is Muromonab. Why the name Muromonab? It is derived from murine, that is a rat or mice, and it's a monoclonal antibody. So it is called Muromonab. And the target is it blocks CD3. If you block CD3, the T cells are not activated. Now where do I use it? It is used in acute organ rejection. So whenever there is acute organ rejection, then we use this Muromonab. Most of your questions will be focusing what is the mechanism of action of Muromonab. So it's a monoclonal antibody derived from murine. Now coming to the target, that is, can we block CD80/86? Yes, we can block the CD80/86, and that is inhibited by two drugs. One is called abatacept and one more is called belatacept. Now I think you have heard of these drugs already in a topic called rheumatoid arthritis. These are used in autoimmune disorder called rheumatoid arthritis. So they are used there. So we targeted the first one, the A place where we can use the immunosuppressant. Number one, Muromonab, that is a MAB derived from murines, and the co-stimulator inhibitor is abatacept and belatacept. So let us understand what happens to the step B, that is the T cell activation. Now what happens inside the T cell? Let me write here. So let me write the T cells like this for you. Now what happens in T cell when the antigen is presented? The CD3 gets activated, so that will activate the IP3. The IP3 will release the calcium. It will release the calcium. Now what happens when the calcium is released? It activates something called calcineurin. Calcineurin is activated. Now what is the role of calcineurin? Calcineurin will dephosphorylate. There is something called nuclear factor activated T cells. So nuclear factor activated T cells, these are phosphorylated. Now when the calcineurin comes to the picture, these are dephosphorylated, so we get nuclear factor activated T cells, and what happens is they will move inside the nucleus. So this is the nucleus, and they move inside. So when they move inside, they cause gene transcription. So the mRNA, from the mRNA what we get is the interleukin 2. So from the mRNA there is production of interleukin 2. So now we have blocked CD3 already. Is there anything else we can block here? Yes. What we can block is the calcineurin, because if it is active, then the nuclear factor will go inside and the interleukin 2 will come to the picture. Now can we block it? Yes. We have certain drugs called calcineurin inhibitors. So we have a drug called cyclosporin. Don't confuse this drug with cycloserine. It's a drug used in tuberculosis. Cyclosporin binds with cyclophilin, and by binding this combination will block the calcineurin. Now one more drug which inhibits calcineurin in urine is a drug called tacrolimus. Now, many a times they will ask you the derivation of tacrolimus. It's a macrolide derivative. Now, this tacrolimus will bind to FK binding protein, and after binding, this combination will inhibit calcineurin. So, this is their mechanism of action. They inhibit the calcineurin. Now, let me again tell you, most importantly, they will ask in the exam, name the calcineurin inhibitors, cyclosporin and tacrolimus. So let me write here the calcineurin inhibitors. So one is the tacrolimus and one more is the cyclosporin. Now where do you use them? The usage is same thing. We use it in organ transplant. We use it in organ transplant, graft versus host disease, and in the management of autoimmune disorders, autoimmune disease. But the adverse effects are most important here. What is the adverse effect of these drugs? Now these are toxic drugs. So let me tell you the story of cyclosporin. Let me tell you the story of cyclosporin. Cyclosporin increases glucose, that is hyperglycemia. It increases potassium, that is called hyperkalemia. The drug is toxic to the nerve, neurotoxic. It is nephrotoxic. So nephrotoxicity is the reason why these drugs are dose limiting toxicity is nephrotoxicity. That means you cannot increase the dose, kidney toxicity can occur, and hepatotoxicity is also a problem. Right. Now, apart from this, it also produces high BP, that is hypertension. It increases uric acid, that is hyperuricemia. And two peculiar problem is the gum hyperplasia can happen. Gum hyperplasia. Now, can you tell me an anti-epileptic drug causing gum hyperplasia? Phenytoin. Very good. And one antihypertensive, CCB is correct. It also produces hirsutism. Now, most of your exam question is, what drug immunosuppressant causes this? Yeah. Now, if you see the toxicity, cyclosporin, it's too toxic, right? So that's why when you are using these drugs, you have to do therapeutic drug monitoring. So TDM is required when you are using cyclosporin or tacrolimus. What about tacrolimus? Tacrolimus is also known to produce neurotoxicity. It is higher with tacrolimus. It's also nephrotoxic, and it is known to increase glucose. So these side effects are very much high with tacrolimus. If both are given, which is more nephrotoxic, it is the tacrolimus. Neurotoxic and high glucose is done by tacrolimus. Now, even this hypertension, hyperuricemia, gum hyperplasia is seen with tacrolimus, but less seen with tacrolimus. These are less seen with tacrolimus. So that is the difference. Basically, remember, I know we have written so many adverse effects, but what should I remember? Remember the gum hyperplasia, hirsutism, nephrotoxicity. These are the things most important to remember. Clear? So we have done with calcineurin inhibitor, that is called cyclosporin and tacrolimus. So that we dealt with the B section, that means the release of interleukin 2. Now the C section, what we need to understand here is what happens when interleukin 2 is released. We know that interleukin 2 acts on the same T cell. What does it do? Let me write the T cell. So this is the entry point, this is the T cell point. Interleukin 2 acts on the receptor called interleukin 2 receptor. Now this interleukin 2 receptor is also called as CD25. It is also called as CD25. And can you just revise the general pharma? Interleukin are acting on which type of receptor? Is it tyrosine kinase or JAK-STAT? Yes, you are right. They are the JAK STAT pathways. So they activate the JAK. So once the JAK is activated, they get phosphorylated and they call the STAT, and the STAT get phosphorylated, STAT get phosphorylated. So once they get phosphorylated, these activate the intermediate, that is mTOR. Sir, what is mTOR? mTOR stands for mammalian target of rapamycin. So it is called as mammalian target of rapamycin. Mammalian target of rapamycin. So once this is activated, then what happens inside the T cells? This is happening inside a T cell, guys. What I am writing is how the T cells gets proliferated. So once this is there, it will give a command to increase nucleic acid synthesis. So there is increase in nucleic acid synthesis, that is purine and pyrimidines. Why do you require? We require them to increase the cell proliferation. So the number of T cells increase. So when the number of T cells multiply, yes, there are more immune cells to fight the antigen. So we have the immune response. So we have the immune response seen here. Now you pause the video and tell me, in this process, where can I block it? Yes, you know it. Tell me, where can we block it? Now we can block the interleukin 2 receptor or CD25. Now what is the drug which blocks this? They are called as daclizumab or basiliximab. So these are used in treatment of organ rejection. So whenever there is organ transplantation, there is organ rejection. To manage that, we use a monoclonal antibodies called daclizumab and basiliximab. Yes, very good. Sir, can we block JAK? Yes, Janus kinase. Yes, we have drugs called tofacitinib and baricitinib. I hope you have heard about this nib already somewhere. Where? They are used in a condition called rheumatoid arthritis, an autoimmune disorder. We can use them. Then, is there any other target, sir? Yes, we can inhibit the mTOR. So we can inhibit mTOR. Let me give it as 1. We can inhibit nucleic acid synthesis, 2. And number 3, we can inhibit the cell proliferation. So let us see these targets. Clear? Yeah. Number 1, we can inhibit mTOR inhibitors. So if we inhibit mTOR in the T cells, they don't proliferate. The example is sirolimus. So sirolimus is used in medicated stents. Medicated stents. So just now we discussed that a patient has coronary artery disease and is on stent. We don't want the stent to close. And what we do is we put the stent with sirolimus, so immunity will not mount on that, it will not close. So sirolimus is used for that. Then we have temsirolimus, then everolimus. We have everolimus. These are used to treat cancers. Because in cancers also, the T cells can proliferate. The cancer cells can proliferate with the help of mTOR. Right? So these are sirolimus, temsirolimus, everolimus. And tacrolimus is a calcineurin inhibitor. That is a confusion you will have in the exam. Tacrolimus is a calcineurin inhibitor. Correct. Now moving on to the next important thing. The second one is inhibiting purine and pyrimidine synthesis. Now there is a drug called mycophenol mofetil. So we write it as MMF, mycophenol mofetil. It inhibits an enzyme called IMP dehydrogenase. Now what is IMP? Inosine monophosphate dehydrogenase. And if you inhibit that, it inhibits de novo purine synthesis. De novo purine synthesis. Now, if purines are not synthesized, there is decrease in T cells proliferation. And obviously, when the T cells are not proliferated, the immune response will suppress. That is one thing. Another drug which inhibit the purine pyrimidine synthesis is a drug by the name leflunomide. The name is leflunomide. Now, the drug leflunomide inhibits an enzyme called dihydroorotate dehydrogenase. So what happens when you inhibit this? It will lead to inhibition of pyrimidine synthesis. Now, if pyrimidine synthesis is not happening, again the T cell proliferation will decrease. So this is what the drugs mycophenolate and leflunomide will go. Now, another drugs which can stop the cell proliferation, what is that? So that is the third important target to stop the cell proliferation. So what we discussed earlier, they stopped the cell proliferation by inhibiting purine and pyrimidine synthesis. Other drugs which stop the cell proliferation are the anti-cancer drugs. Certain anti-cancer drugs are also used as immunosuppressant. I know most of the anti-cancer drug, when we use, the bone marrow gets suppressed. So when the bone marrow is suppressed, obviously immunosuppression, but not all the anti-cancers are used. Example is methotrexate. Methotrexate, we know that it is used in two important autoimmune disorder. One is rheumatoid arthritis and one more is psoriasis. One more is cyclophosphamide. Cyclophosphamide, we use it in cancers, but it is also used in autoimmune disorder, and it is considered the drug of choice for an autoimmune disorder that is called Wegener's granulomatosis. Wegener's granulomatosis. The next one, what we have is again azathioprine. The name is azathioprine, and it's a prodrug. After metabolism, it becomes an anti-cancer drug, 6-mercaptopurine. Now we have a separate drug called 6-mercaptopurine used as anti-cancer therapy, but azathioprine is used as immunosuppressant. So this is used as immunosuppressant, and 6-mercaptopurine is used as anti-cancer drug. So where do you use it? It is used in rheumatoid arthritis and one more autoimmune disorder, that is myasthenia gravis. Myasthenia gravis. Yes. So do we have anything else? Yes, we are missing one important drug, immunosuppressant. They are nothing but corticosteroids. So corticosteroids are immunosuppressant. They decrease T cells more than B cells. So they are known to suppress mainly the cell-mediated immunity compared to humoral immunity. And not only that, they decrease the monocytes, they decrease the eosinophils and basophils. And they also inhibit the neutrophil chemotaxis, and they decrease the interleukin 1, interleukin 2, interleukin 6, and also the tumor necrosis factor alpha. So steroids, corticosteroids are immunosuppressant. We have a separate topic where we have discussed in detail. Right? So this is how we block the T cell activation, guys. So it's a combination of your pathology and pharmacology. You should know the basics. So when the antigen get exposed, the antigen is presented. So we block the CD3 muromanab. There is a co-stimulator, that is abatacept, belatacept, which block it. That is also called as CD80/86. Then calcineurin is going to activate the nuclear factor, and the inhibitors are called tacrolimus and cyclosporin. Then you can block the interleukin 2, and that is called basiliximab and daclizumab. Then we have the mTOR inhibitor. They are called sirolimus and temsirolimus, everolimus. You can also block the JAK, which are used in rheumatoid arthritis, dafidatinib and baricitinib. Then you can stop the cell proliferation by inhibiting purine synthesis. My name is mycophenol mofetil. Pyrimidine synthesis, it is called leflunomide. Don't confuse with levamisole. It's an anti-emetic drug. Or you can use anti-cancer drug like methotrexate, cyclophosphamide, azathioprine, and steroids. Corticosteroids we have discussed already. They are also immunosuppressant. So the first thing is being done. The second thing what you can do is you can decrease the B cell activation. Now, how to suppress the B cell? We have an inhibitor of B lymphocyte stimulator. So this is inhibited. And what is the drug name which inhibits B lymphocyte stimulator? The name is belimumab. So B lymphocyte lowers the immunity. So it is the inhibitor of B lymphocyte stimulator. So this was asked as an exam question. It is used to treat another autoimmune disorder, SLE, systemic lupus erythematosus. Now, apart from that, you know that the cells contain CD factors. You can block the CD factor, CD20 blocker. So CD20 blocker, the name is called rituximab. So rituximab, it is used to treat autoimmune disorder. What are the autoimmune disorder we treat with that? Namely, rheumatoid arthritis and myasthenia gravis. It is also used in cancer therapies, that is non-Hodgkin's lymphoma. One more drug which is CD2 blocker is ocrelizumab. The name is ocrelizumab. Now, where do you use ocrelizumab? Ocrelizumab is used in the treatment of multiple sclerosis. Multiple sclerosis. So this is how we can target the CD factors also. So that is about the B lymphocyte. Now, what are the other targets we have? What are the other targets to suppress immunity? What are the other targets? Now, other targets are, what you can do is, what are the other targets? You can block TNF alpha. So we have TNF alpha antagonist. Yes, what are those? Infliximab, certolizumab, then adalimumab, then golimumab, and a non-mab is etanercept. Now you can remember by the mnemonic ICE age. So these are ICE age drugs. So I for infliximab, C for certolizumab, A for adalimumab, G for golimumab, E for etanercept, and all are used to treat an autoimmune disorder, rheumatoid arthritis. But please understand they can increase the risk of TB, hepatitis B. So you have to do the screening before starting this therapy. They are TNF alpha antagonist. Now, other ways of suppressing immunity, one is we wrote the TNF. You can also block immunoglobulin, for example, IgE. So IgE can be blocked, and the name of the drug is called omalizumab. So omalizumab is a monoclonal antibody used for treating allergy as well as bronchial asthma. You can also block other CD factor like CD6 blocker. It is called itolizumab. Itolizumab is used to treat the psoriasis. Now, the target can be interleukins also. So we have interleukin 1 blocker, and the name is called anakinra. So the name is having kin, that is interleukin. RA stands for, it is used for rheumatoid arthritis. It is used in rheumatoid arthritis. Remember, it starts with A, so it inhibits the interleukin 1, the first letter A, alphabet A. So A for alphabet A, that is 1. Kin for which interleukin? 1. RA for uses rheumatoid arthritis. They can also ask interleukin 6 blockers, and that is called very very important sarilumab, and one more is called tocilizumab, and these are used to treat same condition, that is rheumatoid arthritis. So guys, I have given the list of immunosuppressant, and what is most important you have to learn for exams you are given here. Okay, so these are the major immunosuppressant, and we have discussed them in other topics also, and some of them we have discussed here. So once we are done with the immunosuppressant, we started with the cases. So the first case is a 40-year-old patient needs to undergo liver transplant. So what should we use here? 55-year-old woman with rheumatoid arthritis needs treatment. So take a guess. I have told you so many drugs in rheumatoid arthritis. Let me give a guess. The rituximab, abatacept, belatacept, anakinra, then tofacitinib, baricitinib, leflunomide, methotrexate. Right, these are the drugs used in rheumatoid arthritis. We have a separate topic for that. We'll discuss in detail there. Now, 60-year-old male patient was placed with coronary stent due to coronary artery disease, and the stent is medicated to prevent stent blockade. Why it is medicated and what is the medicine used is sirolimus. Now, it will not allow the stent to get blockade, and we call it as medicated stent. But the question is, when you transplant an organ, example we have taken here is liver, what is the thing what we do, what is the regimen what we follow? So what is the regimen we follow whenever we do the organ transplant? So whenever the organ transplant is planned, first one is we do something called induction regimen. So in induction regimen, we use 3 drugs. The reason is, more the drugs, more you can suppress immunity, and the organ will stay inside for long period. Otherwise, it will be rejected. And you have to choose the drugs in such a way that the mechanisms are different. So either we start with cyclosporin or tacrolimus or the sirolimus plus a steroid called prednisolone, plus we add mycophenol mofetil. So this is the induction regimen. Now the main problem with cyclo and tacrolimus are nephrotoxicity. Then once the induction regimen is done, usually it is given for 2 to 12 weeks. The next regimen what we follow is, after the organ is accepted, we give maintenance regimen. So we use maintenance regimen. Same thing, we use the sirolimus plus steroid plus mycophenol mofetil. So this is lifelong therapy is required, because anytime the immunity may boost up and kick the organ out. So it may be sometimes lifelong also. The next important thing is, there is one more regimen called anti-rejection regimen. Anti-rejection regimen. Now what is this regimen? Many a times what happens, acutely the organ may be rejected. So it is called acute organ rejection. So at that time what we use is high dose of steroid. High dose IV steroids are used. If it is not controlled, we add something called muromonab. I told you this drug. It's a CD3 blocker. And or if it is not going to work, we use anti-thymocyte globulin. So it is called as anti-thymocyte globulin. So this is against so many CD and HLA antigens. So it is derived from horse and rabbit, and it is most allergic because it is obtained from animals. It is called anti-thymocyte globulin. So if it is not controlled, you can also add other drugs like tacrolimus, you can add cyclosporin, or you can add mycophenol mofetil. This can be added. if there is an acute rejection. That is called anti-rejection regimen. So this is what the doctors usually do when they are transplanting. So before starting the transplant, they have to start the induction regimen. Once the organ is there, the doses are lowered, and then we give it as maintenance regimen. Sometimes acute organ rejection occurs, then we have anti-rejection regimen. So that is about immunosuppressant. I hope in this video you understood how do you suppress immunity. So I told you immunostimulant and immunosuppressant. Immunostimulants are BCG, levamisole, and aldesleukin. Suppression you can do by suppressing T cells. How do we do that? By blocking CD3, 80 bar 86, CD80 bar 86, and then calcineurin inhibitors, then mTOR inhibitor, interleukin 2 blockers, then JAK inhibitors, the anti-cancer drugs, the purine inhibitor, pyrimidine inhibitor, and steroids. B cell you can inhibit by inhibiting B lymphocyte stimulator belimumab or CD20 blocker rituximab, acrelizumab. Then we have CD6 blocker itolizumab. You can block IgE also, that is called omalizumab. So that is about immunosuppressant therapy. Thank you all. Okay, so in immunomodulators, we have some additional learning. These are non-core, but particularly important in INH-CT pattern of exams. So it's a summary of some of the interleukin blockers and summary of CD factor blockers. So let us see them. Now, the first one is the interleukin 1 antagonist. The name of it is anakinra. So I told you kin for interleukin, A for the first one, RA for rheumatoid arthritis. It is used in rheumatoid arthritis. The next one is we have interleukin 1, that is interleukin 1 beta, that is antagonized by a drug called, the name is called canakinumab. You can see the kin here. Again, it is the interleukin blocker. It is used in CAPS. So what is CAPS stands for? Cryopyrin. It is called cryopyrin associated periodic syndrome, and it is also used in systemic juvenile idiopathic arthritis. So it is used in CAPS and systemic juvenile idiopathic arthritis. The name is called canakinumab. So that is about interleukin 1. Then we have interleukin 4 antagonist. What is the name of that? It is called DOPI. It is called dupilumab. It is called dupilumab. And where do you use dupilumab? It is used in atopic dermatitis. Then we have interleukin 2 antagonist. I'll write like this. And you know them already. What are these? Basiliximab and daclizumab. These are used in acute organ rejection. So there we use this basiliximab and daclizumab. Then we have the interleukin 5 antagonist, and they are used in asthma. What are those? It is called mepolizumab, then reslizumab, and one more is called benralizumab. So these are all used in asthma. So which asthma? It is used in severe eosinophilic asthma. Severe eosinophilic asthma, we use this mepolizumab, reslizumab, benralizumab. It is called benralizumab. Now we have interleukin 6 blocker. The name is called sarilumab, and one more is tocilizumab. So these two are used for rheumatoid arthritis, And also we use tocilizumab in a storm that is called cytokine storm syndrome in case of COVID-19. That is sarilumab and tocilizumab. Most important is we have another one, that is interleukin 17 blockers. Interleukin 17 blockers, particularly in dermatology, it's very important. It is called ixekizumab, and one more is brodalumab. It is called brodalumab, and one more is called secukinumab. So secukinumab, all these are approved for psoriasis. They are used for psoriasis, particularly the plaque psoriasis. Then we have another one which blocks interleukin 12-23 blocker. The name of it is called ustekinumab. It is called as ustekinumab, and it is also approved for the same condition, that is plaque psoriasis. So already this question had come. So that's why tocilizumab mechanism was asked, and they had asked where to use basiliximab, what is the mechanism of action, they have asked already. So that's why this list is very, very important, and that's why it's particularly important for INICT pattern of exams. So once we know the blocker of interleukin, it's important we know the blockers of the CD factors. Now there is a drug which can block many CD factor and HL antigens. It blocks many CD factors and HLA antigens. It is called as ATG. So what is ATG? Stands for anti-thymocyte immunoglobulin. It is called as anti-thymocyte immunoglobulin. So whatever we discussed till now, they are called monoclonal antibody. This is polyclonal antibody. And this is obtained from the horse and rabbit. So that's why the allergic reactions are very much common with this. And it is used in acute graft rejection. Then we can block CD2. The CD2 factor is blocked by a drug called alafacept. It is called alafacept. So where do you approve this? It is approved in psoriasis. It is used in psoriasis. So wherever the drug comes for psoriasis, very much important. You correlate when you study that in skin, also dermatology. Now the CD3 blocker is, we have discussed already, it is called muromonab. Muromonab is used in acute organ transplant rejection. Acute organ transplant rejection, there we use that muromonab. Now what about CD20 blocker? We have discussed this drug, rituximab. We use it in autoimmune disorder like rheumatoid arthritis, myasthenic gravis. It is also used in non-Hodgkin's lymphoma. One more is ocrelizumab, and that is used for multiple sclerosis. Now CD25 blockers, it's a tricky question. CD25 blockers are nothing but interleukin 2 blockers. What are they called as? Basiliximab and daclizumab. Now these are also used in acute organ rejection as well as for maintenance therapy of the graft. So we can use them. These are the most important CD factors. But one important, I told you, CD6 blocker, and that is called itolizumab. Again, this is used in psoriasis. So these are the additional learning in immunomodulators you have to keep in your mind, and they have asked these mechanism of actions repeatedly in an exam, particularly the INICT pattern of exams. Thank you all.